Today we will be doing shoulder joint, which is also called glenohumeral joints, and it is a multi-axial synovial joint of ball and socket variety, and is the most mobile type of joint, but it's a weak joint. Its articular surfaces are this glenoid cavity along with the head of the humerus. This head of humerus is about 4 times the size of the glenoid cavity. That's why it does not snug into this, and it's lead to weakness of this joint. This labrum is directed laterally and forward, while head of the humerus is directed medially backward and upward. There is a These are about the articular surface. There is an articular capsule which is a fibrous capsules which covers this joint, this whole portion. This is all fibrous capsule of the shoulder joint, and it is attached to the scapula as well as to the humerus. And in this capsule, it extends beyond this supraglenoid tubercle. You can see in this diagram, this capsule is beyond this supraglenoid tubercle. So this glenoid labrum is almost intracapsular because capsule covers whole of this. This is glenoid cavity, and glenoid labrum is a rim surrounding this glenoid cavity, and it helps in making this cavity a bit deeper as compared to without this labrum. So this glenoid labrum is nothing but it's a fibrocartilaginous rim which covers the margin of the glenoid cavity, thus increasing the depth of the cavity. This capsule, it is deficient at two places. One at the greater and lesser tubercle, where long head of bicep brachii along with synovial sheath passes through it between this gap. And secondly, it is deficient between the superior and middle glenohumeral ligament at this portion. Basically, glenohumeral ligament has three parts: superior, middle and inferior. Between this there is a gap, and this point of weakness in the capsule is called foramen of Whitbeck, and therefore anterior dislocation are quite common in shoulder dislocation, though the most common are inferior dislocation. This capsule is lax at this portion because when the arm is abducted, the capsule becomes pulled up and is taut. But when the arms are in by the side of the trunk, the capsule is lax. So the capsule has two openings. One is between greater and lesser tubercle through which long head of bicep brachii passes, and second is between the superior and middle glenohumeral ligament, which is called foramen of Whitbeck, through which dislocations are quite common. Secondly, there are few ligaments also. One is transverse humeral ligament, which basically converts this into a tunnel through which this long head passes. Second is glenohumeral ligament, which has three parts: superior, middle and inferior, and this inferior part is the most well developed of all the three, and it extends between the middle of the anterior border of glenoid labrum and the lower part of the front of the anatomical neck. You can also see this glenoid, this capsule, it extends beyond the anatomical neck, comes to in the inferior portion up to the surgical neck, and here it is. You can see this is coming down like this, but when there is abduction, it becomes taut. So we have discussed about the articular surfaces, about the articular capsules, about the ligaments. Now there are few factors which help in maintaining the stability of the joint. First is glenoid labrum, which increase the depth of this glenoid cavity. Second is rotator cuff, which includes four muscles. This is rotator cuff: supraspinatus, infraspinatus, teres major, teres minor and subscapularis. It is called rotator cuff or musculotendinous cuff. Another is coracoacromial arch, acromion, coracoacromial process and coracoid process, which helps in preventing the upward dislocation of the shoulder joint. So these are three structures which help in maintaining this stability of a joint. Now we have a few points about the bursa of the joint. Basically, the shoulder joint has three bursa: infraspinatus bursa, infraspinatus, subacromial and subscapularis bursa. This is subscapularis bursa, this is infraspinatus bursa, and this is subacromial bursa. Subacromial bursa, it is the longest bursa and it does not communicate with the glenoid cavity, while infraspinatus bursa and subacromial bursa, they communicate with the glenoid cavity. This capsule, this fibrous capsule, it is covered, it lines the, this is lined by the synovial sheath, and this synovial sheath also covers the glenoid labrum. So there is synovial sheath and inflammation of the synovial sheath can lead to a frozen shoulder. As far as blood supply is concerned, it is basically circumflex humeral vessels, both anterior and posterior, and few branches of suprascapular and subscapular. Nerve supply is basically by axillary and musculocutaneous nerve.